Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is 20th August 2025. This video is on renal denervation for hypertension, published in Nature Reviews Cardiology this year. Renal denervation therapy is a catheter-based procedure performed in the cath lab. It ablates renal sympathetic nerves. It lowers blood pressure independent of medication adherence. Typically reduces blood pressure by about 5 to 10 millimeters of mercury versus sham, similar to adding one more effective antihypertensive drug. It was approved by the FDA in 2023 for both radiofrequency and ultrasound systems. Evidence and efficacy: Sham-controlled trials, spiral, radiance hypertension consistently show modest but clinically meaningful blood pressure reduction. The effect is observed in mild, moderate, and resistant hypertension. Response rate: 2/3 of patients achieve equal to or greater than 5 millimeters of mercury reduction in ambulatory systolic blood pressure. Largest benefit in patients with higher baseline blood pressure. Blood pressure lowering is durable in registries up to 10 years, though longer-term randomized data are limited. Safety: excellent safety profile up to 3 years in randomized controlled trials, longer in registries. Periprocedural complications include vascular injury, renal artery dissection, are rare. No evidence of impaired sympathetic response to hypotension. Imaging is essential before procedure to exclude renal artery stenosis. Patient selection: not a first-line therapy, best suited for truly resistant hypertension, uncontrolled blood pressure despite 3 or more medications, including a diuretic, patient intolerant of more medications, patients unwilling or unable to take medications, requires confirmation of sustained hypertension using both home and ambulatory blood pressure monitoring. Secondary causes, especially primary aldosteronism aneurysm, must be excluded. Clinical guidelines: ESC in 2024. Renal denervation is class 2B for resistant hypertension, class 2A for uncontrolled hypertension at high cardiovascular risk, even on less than 3 drugs. ESH 2023, option in uncontrolled blood pressure despite combination therapy or in drug intolerance. AHA 2024 emphasizes shared decision making and multidisciplinary hypertension teams. Patient preference: 30 to 40% of the patients with uncontrolled hypertension would prefer renal denervation therapy over additional pills. Strongest interest in those with medication side effects or pill fatigue. Patient preferences often differ from physicians, underscoring the need for shared decision making. Implementation: requires hypertension specialists and trained interventionalists, needs structured pathways, follow-up with standardized blood pressure assessments, and close coordination between interventionalists and referring physicians. Uptake may depend on reimbursement decisions. Future directions: expansion into underrepresented populations, including women, blacks, Hispanics, and Asian patients. Study in CKD, elderly and isolated systolic hypertension. Potential broader indications: atrial fibrillation, ventricular tachycardia, sleep apnea, and metabolic syndrome. Transition towards radial access devices to simplify outpatient procedures. Bottom line: renal denervation therapy is now an FDA-approved safe and effective adjunct for uncontrolled hypertension. It offers a durable pill-independent blood pressure reduction similar to one medication and may help reduce long-term cardiovascular risk. Proper patient selection, shared decision-making, and integration into hypertension care teams are critical for its successful use. Historical perspective: Smithwick sympathectomy, first reported in 1950s. Thoracolumbar sympathectomy of severe hypertension, effective but high morbidity. In 2009, Henry Crum and Murray Esler published the Simplicity Hypertension 1 trial, first in human catheter-based renal denervation in Melbourne. This is associated with decreased blood pressure and norepinephrine spillover. This was followed by Simplicity Hypertension 2, Simplicity Hypertension 3, Spiral Hypertension, Radiance Hypertension, Dener Hypertension, HTN trial by Michael Azizi, Radiosound Hypertension, Target Blood Pressure 1, and FDA approval in late 2023. Who was Smithwick? Richard Smithwick was an American surgeon at the Peter Bent Brigham Hospital in Boston, now a part of the Brigham and Women's Hospital or the Mass General Brigham. Key contribution: developed and popularized thoracolumbar sympathectomy for severe hypertension. Landmark work: 1953 JAMA report, sympathectomy for essential hypertension in 1,266 patients. Impact: first effective intervention for malignant and severe hypertension, dramatic blood pressure reductions, improved survival. Limitations: high morbidity, orthostatic hypotension, bladder and bowel dysfunction, and sexual dysfunction. Legacy: this procedure was abandoned with the rise of effective drugs, including thiazides. It paved the way for catheter-based renal denervation concepts. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.